Good morning, everyone. Thank you for the time and opportunity to talk about this topic of hematospermia. So today we are going to talk about hematospermia, which is a symptom with many possible causes. So generally, hematospermia is a rare symptom for patients who are coming to urology clinic. Sorry, can you guys see my screen?
No, we don't.
Yeah, okay. Let me just start over. I'm sorry. All right, thank you very much for mentioning that. So hematospermia, a symptom with many possible causes. Hematospermia is rarely seen in daily practice, and the prevalence of it is actually not that much among all the patients, all the urology patients, and actually that was the reason that I chose this topic. There might not be many good quality studies in the literature about this, because most of the series are case series, but actually because of that, there's also a lot of confusion about how to approach hematospermia and how to actually work up and possibly treat them. All right, so what we will start with will be a definition of the hematospermia, what the epidemiology among the patients are, what is actually the clinical significance of hematospermia? Is it always important at all or not? And then what etiologies can cause hematospermia, diagnostic workups, different approaches that different people and different systems actually have about hematospermia, treatment indications, and some review of literature, and finally we go we take home message. So as you know, and as we can find from this, hematospermia is the presence of blood in the seminal vesicle. It's also known as hemospermia, and the blood is sometimes visible to the naked eye, but also the term hematospermia also, sorry, I'm getting some echo. Sorry, can you hear me? Yeah, this should be okay. Sorry. But also, the term hematospermia covers the microscopic seeing of blood in the ejaculate, which is occasionally detected incidentally in the spermogram. But, is it a common finding? Typically not, because patients who come to our urology clinic usually don't come with a spermatozoa analysis or semen analysis in their hands, but for some reason, they've seen some blood in their semen and ejaculate, and sometimes probably it's a pseudo hematospermia that is coming with urine or from the sexual partner, and it typically causes a lot of anxiety. So, I mean, most people, when they're talking about hematospermia, they're mainly mentioning that gross or visible hematospermia, which is seen in naked eye. So we should discriminate, as we said, from what we call it pseudo-hematospermia, because of similarity of some of the origins of hematuria and hematospermia, and actually both coming out from the urethra. There might be hematuria as a pseudo-hematospermia. Also, sometimes blood from a sexual partner genital organs may be mistaken for hematospermia. It may occur once, it may be post-procedural, it may be sporadic, or it might be chronic or persistent, which we call the persistent hematospermia. That is more actually important for doing some workups. What I saw in the literature, the criteria for calling it acute hematospermia versus chronic hematospermia is usually 1 month period. Right. It makes up to 1% of all urological symptoms. And its prevalence is estimated to be about 1 in every 5,000 urological patients, which makes sense because many of the urological patients may have similar urologic symptoms. So actually 1% of the whole urologic symptoms, but 1 in every 5,000 urologic patients may come with hematospermia complaint. In a series of 26,126 patients who underwent routine prostate cancer screening, and this has been so far the largest series that has looked into the hematospermia and its prevalence. They found that, in people who are screening for prostate cancer, there is a 0.5% report of hematospermia, which is 25 times more than the general urology patient population. So it's something to consider. I will show a document about this and literature that, why this thing is important. And these patients are usually younger men under the age of 40, as shown in 6 large series, each including over 500 patients. Interestingly, we have great Navy urologists that come and scrub with us sometimes, and we were talking about this yesterday in the OR, and because of the kind of population that they deal with, they said that we get a lot of referral. And that also makes sense that, younger and active men, they may have a lot of hematospermia, and that was very interesting to them. So about the microscopic versus macroscopic hematospermia, well, there was a study on a large urological department in 2015 in Germany, and erythrocytes, RBCs, were detected in ejaculates of about 14% of men who underwent semen analysis for infertility. So that's also another population or group of patients that have higher prevalence or report of hematospermia. But that's also expected because, many of the times infertility goes with many of abnormalities of the genital ducts and infections in the area. And as we will discuss, these are the reasons that cause hematospermia many of the times. So, if we test more, if we use more sensitive tests, probably we will find more subclinical form of a complaint in urology, but are of them significant? Probably not. So erythrocytes are also found in semen. Yes, sir.
So when you say 14% seems to be really high, is it patient complaints of hematospermia or the microscopic appearance of RBCs or just the appearance? The definition needs to be needs little clarification because 14% is seems to be really high for general population.
Yeah, correct. That's a very good question. Well, the reason that I put this study was the comparison of microscopic and macroscopy. So this was a study that was specifically done on a group of infertility patients, and they looked in semen analysis for finding RBC. So this group means that, this 14% is reported microscopic hematospermia. So I don't know how many of them have had gross hematospermia. I actually, didn't see that report in this, but this percentage that I'm saying is that, this is the microscopic hematospermia. If we do semen analysis in every patient that comes to infertility clinic, there's a chance that we see, RBC in some. But again, that was a series in Germany that was done, and this is not macroscopic or gross. That was the microscopic. Okay. So anyway, erythrocytes are also often found in semen when it is harvested in rectal electrostimulation. And, they're merely kind of concomitant findings. They're not a pathological value. What is important and what we have always observed is that seeing blood in the ejaculate is a very, very kind of stressful occurrence. And most of the patients and couples become very, very disturbed and anxious because of this finding, and they come with, presumption that they have even a very serious infection or some sort of cancer, and they seek medical advice because of that. So it's very important to stay on the top of it, know what are the red flags, know what is the significance of this disease, and, treat the patients or guide them accordingly. So I put this slide as the standard semen analysis. And if we look at it, and if we look at the comparison of WHO criteria and AUA criteria, which, for the AUA, it's a little more strict, and WHO, actually, the cutoff value is usually lower. What it means is that, to go down the road from, the ejaculate volume, pH, the regular kind of variables in a semen analysis that we look at, usually we look at sperm concentration, sperm count, motility, progressive motility, normal morphology. Each of them have some kind of degrees and numbers. As you come down for the leukocytes, we also have something which is discussed, but there's no place for RBCs. So actually, RBCs are not that much, noticed or regarded in a regular semen analysis, and people usually don't look for them. And I again think, the reason behind this is the microscopic hematospermia, can be a finding with many, many reasons, can have a very high prevalence without the real clinical significance. So even those who put the criteria don't bother going too much through, how many RBCs is normal and how many are not. That's another evidence that probably, gross hematospermia is more of a clinically significant thing to look at rather than microscopic. So let's talk about the etiology. So historically, hematospermia was viewed as a consequence of either prolonged sexual abstinence or excessive sexual activity. And, Campbell also talks about this, that for people who have had abstinence for a while, they may see blood after a while because, the prostate is very engorged and all the vessels are kind of, engorged, and probably kind of aggressive sexual activity may cause hematospermia. But also, deviant sexual behaviors can cause bleeding by trauma. And this can be the injury to the prostate by a stimulator, and also damage to the urethra, prostatic tissue, prostatic urethra, with either foreign bodies or a tight penis ring from outside. So, Western Section AUA has a around the table session at the last day of the meeting. And essentially just looked at as a kind of fun part of the meeting, because all the cases that are reported there are actually these external genitalia, very deviant sexual things, multiple rings, people who use their genitalia for powerlifting, and all the consequences that has happened. And the reason that I put this picture on the right is that this is an Apple pencil that we removed it from inside the bladder. So, I mean, probably the person was trying to use Apple pencil as an IPP, but, the Apple pencil can also cause hematospermia. So what I'm saying is that generally there are lots and lots of deviant sexual behavior that can cause hematospermia, and this we see it a lot. So even in the recent decades, the exact etiology of the hematospermia remains unknown, even after extensive workup. Okay, so if we want to
if I may add, Sarush, I found
Please.
one of those myself one time.
The Apple pencils?
Yes. Mm-hmm. A big
Oh,
pen.
great. Yeah, okay, so, probably, we should communicate with these authors to add Apple pencil as cause of hematospermia in this table. All right, so recurrent or chronic hematospermia that is a more important cause that, they usually, these kind of causes are referred to, but also, they may be happening with the acute hematospermia as well. But what are these causes? So if we want to put them in tables, there are different authors that looked at them from a system point of view versus from the pathophysiology point of view, but we can generally categorize them in these categories. So there are infections as not the first most common, but we talk about that. Infections like STDs, gonorrhea, chlamydia, syphilis, treponema pallidum. There might be infection by the agents that are causing UTIs, and because of that, they are causing prostatitis. That is the most common infection that causes these. Well, they're usually gram-negative bacteria like E. coli and Enterobacteriaceae. And there are a specific and kind of, endemic areas infections. And the top of them is schistosomiasis or schistosomiasis and tuberculosis. But that really should be in the endemic areas that we look or work on for them. Anomalies. There might be, congenital anomalies of prostate, like, polyps, cysts, stones. We know very well, remnants of the Mullerian ducts. We know the prostatic utricle, and that is something, I saw a full study that, they focused on the reasons of persistent hematospermia, and they went too deep into even endoscopic view of all these kind of pathologies, and utricles, prostatic utricles was really, really discussed a lot there. So seminal vesicles, they may have cysts, diverticuli, and stones, and we have seen these kind of masses or fluid-filled cysts of seminal vesicles as well. There might be malignancy and tumoral causes. Prostate cancer is on the top of the reasons for hematospermia. Then seminal vesicles can have their own carcinomas and also some hematologic diseases, lymphoma, leukemia can cause hematospermia. Well, maybe because of, the tendency for bleeding, or maybe because of the involvement. And very interesting, there are metastatic melanomas that can happen to seminal vesicles. And one of the famous or maybe notorious ones is melanoma, that usually metastasize to very abnormal and unexpected locations like seminal vesicle. Well, we put it at the end of the list. Then we have iatrogenic causes. Iatrogenic causes are the most common causes of hematospermia. So, like, prostate biopsy, each of us have done a handful of them, and each of us have seen people that, they are instructed that you will have hematospermia for a couple of weeks, and we have seen many of them come back to clinic with hematospermia. So, as a general rule, post-procedural or iatrogenic causes are the most common cause of hematospermia. And also we have systemic disease, arterial hypertension, anticoagulation, liver disease, and also deviant sexual practices that we talked about this that can be discussed as the other etiologies. So this table is another way of looking at it, and that's more, looking into organ-specific rather than cause-specific. What the information or this summation of information found from case series is that under 40 years of age, which is the ages that most of these cases are seen, almost always the result is a benign condition. But, there might be no clear-cut cause of these be identified even after extensive workup. Cancers are rare, occur almost exclusively among the patients above 40 years of age, and I would even say more than 50 years of age. And if, there are a couple of these reasons that are called serious causes of hematospermia, they almost never happen under age of 30. So I skipped this part. So this was a study that was about the association of hematospermia with prostate cancer. As we said, that was almost the largest studies or series that have looked into hematospermia, and that was on 126 men who were screened for prostate cancer. So prostate cancer was diagnosed in 19 of 139 men who reported hematospermia upon entering the prostate cancer screening. So this is about 14%. That's different from the other one, but if we look at the population who are screened for prostate cancer per this study, those who have hematospermia, they had a 14% chance of having prostate cancer. On the other side, hematospermia is rare in prostate cancer screening population, 0.5% that I showed in the first slide. But this, again, compared to 1 in every 5,000 general urology patients, it's 25 times more. So they did a logistic regression modeling of hematospermia that was significant. Hematospermia was a significant predictor of prostate cancer diagnosis after adjusting for age, PSA, and DRE. So discussing a little more.
Sarosh,
Yes,
I will go back to the previous slide. I'll be a little bit cautious here. The p-value is 0.054. The evens are so small. I'm not sure I would call this a significant predictor. Okay.
Yeah, I agree with you. I mean, especially, in the multivariable and logistic modeling, they probably found a trend, but they reported it as it was a significant predictor. Maybe in the univariate, they found a significant association and they wrote it like that. Thank you very much for mentioning that.
Yeah, no, the thing is, this is clearly a selection bias. You see, what they've done is they've taken 139 men who actually had hematospermia, and 19 of them had cancer, and there it becomes a predictor. But if you look at the entire cohort of 26,000 men, hematospermia is so infrequent, it would not be a predictor. So it's a way they've interpreted this data, and I want you guys to be nuanced in looking at this. We'll talk more about data interpretation in our workshop, but this is a great example of that. Okay, thank you.
All right. So going a little more into the pathologies and etiologies that are causing this, as we talked about, post-procedural or iatrogenic causes are the most common cause of hematospermia in prostate biopsy. So up to 80% of biopsy patients experience some sort of hematospermia, and that lasts usually for 3 to 4 weeks. So it's also common after radiation treatment of prostate cancer, 25% after external beam radiation, and 17% after brachytherapy. Patients may develop some degrees of hematospermia. Interestingly, vasectomy by itself can cause hematospermia for a week or more. As we taught, instrumentation like cystoscopy, as well as insertion of foreign bodies, they all can injure the vessels around the prostate neck, and may cause hematospermia. And there are further possible trauma causes, and those include the injuries to the pelvis, perineum, genitals, those severe pelvic fractures that can injure the area and cause the bleeding. So infections are the second most common cause, most frequent cause of hematospermia. So there's 15% in men under 40 years of age and about 10% in men over 40 years of age. The most likely infection, as we thought, is prostatobasicolitis, and pathogens are those who are responsible for urinary tract infections, E. coli, Proteus, and Klebsiella. But what to remember is that hematospermia is not a typical symptom of chronic prostatitis, chronic pelvic pain syndrome. So then later on, when we discuss about the treatments, then many authors have recommended empirical treatment for a presumed chronic prostatitis as a cause of hematospermia. So we will talk about that. STDs like chlamydia, Neisseria, and Treponema pallidum, and the first two, they definitely need actually workup in the patients with persistent hemophilia. So viral cytomegalovirus and Zika virus, that the epidemic of it just happened and finished. Interestingly, even there are studies in Campbell that Zika virus can cause significant hematospermia in the urology field. And there are specific infections like tuberculosis, schistosomiasis, but they usually go to the endemic areas. So organ-related causes, obstruction caused by cysts of the seminal vesicles, might be congenital, might be acquired, obstruction of the Mullerian duct or the ejaculatory duct, polyps, condylomas, or strictures of the urethra, AVF, hemangiomas, and other vascular anomalies. They can cause hematospermia that may be significant, especially in vascular anomalies. So there are systemic causes as well. We talked about arterial hypertension causing that, hematologic conditions, hemophilia, coagulation disorders, anticoagulation. That interestingly, the anticoagulation, can also cause hematospermia. Again, we just go with conservative treatment and wait for 1 month to see how it can help the patient. We will talk about in the management. So severe hepatic disease and one other factor that has been seen associated with hematospermia has been hyperuricemia. This increases risk of hematospermia, and we know that parts of the reason for hematospermia might be obstruction of the ejaculatory duct, and stones is one of the causes. They usually post-infection, but hyperuricemia may also play a role. So, talking about diagnostic workup, as we said, there's not much in the literature to research as a good publication, good quality, and high level of evidence. So most of the approaches are individualized, based on expert opinion, and not much evidence-based. So what is important is that of all that big table that we talked about, searching of rare causes is not likely to be productive. So we shouldn't just upfront go and screen the patient for schistosomiasis, of course. So of the medical history, early exclusion of pseudo hematospermia. So we should be very cautious what patients talking about. It's not hematuria, it's not blood from the sexual partner. Then a detailed GU history is usually the beginning of this, with focus on iatrogenic causes, infections, if there's any, LOTS, bladder outlet obstructions, if there's any pathologies of the prostate, which is possible. On physical exam, we do complete inspection examination of external genitalia, including the spermatic cords, epididymis, and DRE of the prostate and seminal vesicle is something that should be done for sure in this group to see if there is any palpable abnormality. And apparently, if there is anything, we go to further evaluation by some sort of imaging. So on the lab test, urinalysis with reflex to culture is the first and only test which is recommended, for these patients. So urinalysis, if there is any signs of infection, we go for further workup. We may see signs of chronic bacterial prostatitis, and we may go further for either treatment or workup tests, but nothing like seminanalysis or semen culture is recommended. So seminanalysis, although we said that there's macroscopic or microscopic features in it, and it can differentiate between the hematospermia and discoloration of the semen, as seen in the slide on the right, but it's not routinely recommended. For men over 50 years of age, there are a couple of studies that are mentioning that in the group screened, if there is hematospermia, there is a slightly higher chance of prostate cancer. So we can discuss patients about screening them with PSA. And special tests, go to endemic areas for those infections. About the imaging, transrectal ultrasonography is, as you know, safe, minimally invasive, inexpensive, that can investigate the structures that have causal role, possibly potential causal role in hematospermia. MRI, particularly with endorectal coil, is the most sensitive in pathologies and prostate cancers. And well, nowadays we have the 3 Teslas. We don't need the endorectal coil, but this is the most sensitive, and this is the second line in imaging. Doesn't mean that every of these patients should go through these imagings, but we'll talk about the indications. Cystoscopy may also locate the exact site of bleeding, and parallel prostate massage may be helpful in localizing bleeding. People and investigators have gone even further down to invasive transurethral vesiculoscopy. They place a guide wire and they go there with a tiny scope and investigate inside the ejaculatory ducts for sources of bleeding. And I saw a study from China that they investigate about 400 cases of persistent hematospermia, and there were pictures of all these invasive vesiculoscopy. And I don't know, how much clinical significance it had, but they found a group of 4 different type of abnormalities that they could see in this. So it was, out of the scope of this talk to go there. But, it's interesting that people do and investigate these things, although at the moment it's largely experimental. What's important about imaging is that not in acute phase, but all patients with persistent unexplained hematospermia, which usually means lasting longer than 1 month, should be evaluated with the first-line imaging, which is the transrectal ultrasonography. So about the value of transrectal ultrasound in diagnosis of hematospermia in large cohort of patients. Well, there were 270 patients in this study with hematospermia. They were evaluated by TRUST, and they found 3% malignancy in those population. Of course, they were of different ages, but there was a significantly higher percentage of malignant disease, prostatic calcifications, and benign prostatic hyperplasia in a group of patients more than 40 years old. And they also found a variety of minor abnormalities and, abnormalities of the ejaculatory ducts and congenital forms that, was found, not necessarily of clinical significance. So talking about the treatment principles, the plan of action depends on a couple of items. First, the extent and duration of the hematospermia.
Sarosh?
Yes, sir.
Could we just pause here for a little bit, go around the room, ask people, if somebody, a 40-year-old comes with a history of hematospermia for the first time, how many would do the evaluations, a further evaluation on that patient? We'll go through the,
I saw one yesterday. I got a urinalysis. It was benign. It was a trace amount of blood. He's a 40-year-old man, actually had a PSA that was normal. I didn't do anything else beyond that. No symptoms. 1 episode.
Okay, how about other attendings?
The same here. We have seen probably maybe around 10 cases in the last 1 or 2 years. It's not uncommon to see referred patients. Probably we got MRI in 2 because 1 patient had hematospermia persistent for a year. So, but if it is first episode, the first question is abstinence time and any chronic pelvic pain or any infection symptoms. If none of them, reassurance. If recurs, if patient is willing, then we go for further investigation other than the clinical and urine examination. MRI, if it is only selected, very selected patients. Vesiculoscopy, similar vesiculoscopy is kind of very investigational, their long-term outcomes, and probably the stenosis of the orifice is very common after dilatation. Particularly, for scope instrumentation, we need to dilate at least 8 fringe. Then the stenosis rate is very high. So those kind of investigations are very subjective and investigational. MRI is very practical, but in very selective patients.
So any other comments on any of the other factors?
So if blood persists beyond several weeks, say 1 month, then workup or further workup is indicated. But, not to forget that even after extensive medical workup, the cause of hematospermia remains unclear in up to 70% of the cases, which means, we probably won't be able to provide any causal treatment. So this is an algorithm for evaluation of acute hematospermia. Sorry if text is a little small, but I had to include the whole thing. So I'll go over it very quick. Found it from a couple of sources as well as the up-to-date. Acute hematospermia, which is present in 1 month or less. So is there any instrumentation in the recent history of the patient? As we said, the first cause of it is post-procedural. Prostate biopsy instrumentation, or maybe other treatment like radiation brachytherapy in the past 6 weeks. And if yes, then this yes goes observe the patient for 1 full month with reassurance that this is a self-limited condition and this will go away. And this also includes patients who have been on anticoagulations and antiplatelet drugs. So if there's no instrumentation, then we go to history of malignancy, prostate glands, semivesicles, melanoma, other kind of, malignancy the patient may have. That is usually the group of patients above 40, 50. And those kind of patients, usually don't end up having a single episode or acute hematospermia only. But anyway, this is something that runs for the workup. And if the patient does not belong there, then we perform the urinalysis with microscopy as the only test on the first line, okay? And then if there is any signs of pyuria, then bacterial cultures is usually requested. Is there any bacterial urinary tract infection? We go to the other column. Sorry, let me change this. All right. So if yes, then we treat the infection accordingly. And if there is not, then symptoms of urethritis, pyuria with bacterial infection, without the bacterial infection. So then that's the place that we go for testing STDs, chlamydia, gonorrhea, and trichomonas. If they're positive, treat accordingly. And if there are none of them, so we go to the third kind of uncommon infections. Is it an endemic area that those infections are there? And again, if it's no, so then we consider this is probably an acute episode of sporadic hematospermia, and we just observe the patient in 1 month. And after 1 month, if there is resolution of hematospermia, probably no further workup is needed. But if it is not resolved, this becomes a kind of persistent hematospermia, and we go to the next level. So talking a little more in detail about treatment of acute hematospermia, reassurance is the most important step. It's the most important therapeutic intervention. We need to address patient anxiety and concerns that it is not cancer. And if it's a stage post-procedural, such prostate biopsy, it will be self-limited within a few weeks. Patients with identified abnormalities, we treat them accordingly. And structural abnormalities of the urogenital tract, such as Mullerian duct and those stuff, they may be treatable endoscopically, but they usually fall in the non-acute phase. There is a limited role for presumptive prostatitis therapy, which means, there's no evidence actually that empirical antibiotic treatment of the presumptive diagnosis of prostatitis is effective, because we said that prostatitis, which is chronic, specifically chronic non-bacterial CP/CPPS, there's no evidence that it causes hematospermia. So that's why treating it according to that is also not recommended. And the fact that in some of the others' results and publications, they say that, hey, we treat this patient and after 1 month it went away, we know that hematospermia usually resolves spontaneously during this period. So there is no evidence for kind of empirical antibiotic therapy. There are some emerging therapies, and finasteride may be used in refractory symptoms. So there was one trial of refractory idiopathic hematospermia that was a short number, 24, and resulted in about 67% of finasteride group in 3 months. Also, endoscopic holmium laser therapy may be used in ejaculatory duct obstruction or calculi, but those are also for specific causes. So if there is persistent hematospermia, those patients who extend beyond 1 month, and those patients whose hematospermia does not resolve after a period of treatment of infection causes, then these patients are the ones that should be evaluated with transrectal ultrasound. So we talked about this several times. So beyond 1 month, no treatment response, go for imaging. MRI, magnetic resonance imaging, a good quality one, or with endorectal coil is the second line of the imaging. And the studies suggest that if we do MRI for hematospermia, probably we will end up doing higher than expected or required prostate biopsies. So that's why they don't recommend it as the first line. And of course, the prostate cancer screening, any patients over 50 years of age, especially if they have the hematospermia, there's been studies that shown, it's maybe associated prostate cancer, so we can at least discuss it with patients that we can do the screening for them for prostate cancer. On the other side, there are European publications that also investigated them. There has been a couple of systematic reviews that they mainly review articles, and they had a more liberal approach toward using of diagnostic tests and treatments. So in their approach, every patient, after history physical examination and ruling out of pseudohematospermia, they verified by a spermogram. And then urinalysis is done, all the cultures, coagulation abnormalities, and scrotal ultrasound plus a truss was recommended. And if it's less than 40 years of age, if any pathology is found, we treat according to the cause. And if no pathology is found, then, even they allow empirical treatment with NSAID and maybe a course of a month of antibiotic like doxycycline, azithromycin, or quinolone can be given, and patients re-evaluated after a month whether this is a recurrent case or it's not a recurrent case. And their criteria for doing the PSA was about 40 years of age, and then MRI and cystoscopy. So that was quite different from the evidence that I found and from what UpToDate recommends and what our urologic resources recommended, but it was worth mentioning anyway. So the take-home message from this topic is that hematospermia is almost always a benign condition. There are multiple causes. The most common etiologies is prostate biopsy and post-procedural. For patients who are otherwise asymptomatic, the initial evaluation only consists of history, physical exam, and urinalysis. Men with hematospermia and symptoms of urethritis should be tested for gonorrhea and chlamydia, and persistent unexplained hematospermia, which lasts longer than 1 month. Those are the cases that we go one step further in diagnostic evaluation, and we do truss in there. In most cases, the evaluation anyway will not end up or identify a clear cause of hematospermia. So the most important therapeutic intervention is still the reassurance. And the condition will usually self-resolve. It resolves spontaneously. And for men over the age of 50, is a specific group, a special group that if they have history of hematospermia, we should offer PSA testing for screening of the prostate cancer. Thank you very much for your time and patience. Any questions, any comments? I'd be happy to answer.
Any comments from the attending though? Do we need to be this aggressive and somebody with, in terms of investigating somebody with hematospermia?
In our center, we don't have the option to order for the transrectal ultrasound. We can do it ourselves with the biopsy probe, but we cannot bill for the service. So practically, we are left with only one option, MRI of the pelvis. To go to that extent, persistent hematospermia and not resolving. If he has any symptoms suggestive of, even mild pain or anything suggestive of chronic prostatitis, we go for the antibiotic for at least 3 to 4 weeks. The European recommendations are a bit more aggressive. Their antibiotic regime is like it covers all STIs, and that seems a bit more aggressive. So we know and we discuss this with the patient. Most likely, we are going to end up with no diagnosis. Still, for reassurance, we can do MRI if it is persistent hematospermia.
Okay.
Yeah, I agree. That's a good, graph actually.
I mean, the traditional teaching has been, it's usually benign etiology, the frequency is low. So one episode here and there, we reassure patients. Anything persistent, of course, in addition to urine analysis and IRB and so on, I'm sorry, gonococcal chlamydial culture and so on, is really to probably get some form of pelvic imaging and just to look at unusual causes, which is pretty rare. That's been practical. I'm not sure about scrotal ultrasound and all that will yield much more than a physical exam. If a physical exam is totally normal, where our physical exam may not be as accurate as the prostate and the seminal vesicles and so on. That's why we get a pelvic imaging. So, in terms of hematospermia, I would just be careful that occasionally, you could have a rare case that can show up. So we just need to be aware of it. So when you discuss with patients, just let them know that the yield is generally low, but there are rare cases and document as such. So if you ever come with a rare diagnosis, we have documented it. Okay. Any other thoughts or questions? Okay, thanks everybody. I'll see you guys in a few minutes, faculty, residents, and fellows at the photo shoot. Thank you.
Thank you.
Thank you.